Thank you. Any message in the chat? Shall I wait or can I get started?
I think we can get started, Mary. I see Dr. Robson here, although I don't see Sandy just yet.
Sandy and Milena will join when they can. I think that the expectation is they'll join whenever their clinical duties are done. So hopefully they're wrapped soon, but we can get started.
Okay, great. Thank you, Jonathan. So that's it. We go ahead. I'm going to start with the territory acknowledgement. So today we have the privilege of coming together on the unceded Musqueam, Squamish, and Tsleil-Waututh territories. May we recognize this honor and approach our work with honesty and compassion and understanding.
Slide deck.
I'm sorry?
Are you showing your slide deck right now?
Oh, I apologize. Okay, let me go to Zoom. Display. Is this better? Thank you. Sorry about that. So today we have the privilege of coming together on the unceded Musqueam, Squamish, and Tsleil-Waututh Nation territories. May we recognize this honor and approach our work with honesty, compassion, and understanding. So the agenda for today would include the introduction and housekeeping. We'll be reviewing the encounter types and medical service for this clinic. We'll go over the clinic workflow. I see Sandy is here. Okay. We'll do a demo and then review orders and documentation, recap, go through any questions, and talk about next steps. So today we have Mary Escobar saying her regards, but we do have Jonathan joining us. We also have Sandy as the PCC and Dr. Robson. And as I just informed, Milena will be joining us when she's able to. And then I have the CS team with us. My name is Mary. I am the clinical informatics. I will be helping this clinic go live activation with CST Cerner. As this is the validation we've met before, so I'm just going to skip over the introduction, unless there's someone here that is not included in this list. So please mute when you're not speaking. Please state your name when you are asking questions so I can have able to address you. I'm not really good at recognizing voices, so that would really help me. Any questions, feel free to put into the chat. Again, I'm just going to ask you to help me monitor that. And this session is being recorded by Zoom. So the purpose of the session is to validate the future state workflow of the Richmond Health Services Colposcopy Clinic. This includes orders to scheduling, day of exam workflow, and interpretation of workflow. Clinical logistical information. Okay, so for the colposcopy clinic, the location name we have is stated as such, RHS Colposcopy, and the medical service will be gynecology. Is this satisfactory with the clinic?
Sandy here. Yep, that sounds good.
Okay, thank you. And just to refresh what work queue monitor is. This is the electronic fax queue that the clinic will be using to receive external faxes. It will show up in a electronic queue, and the queue is called RHS Colposcopy. And as we stated earlier, because currently the clinic's fax number is shared with other ambulatory care units, a new fax number will be established for the RHS Colposcopy clinic. And do we have the clinic's thumbs up for the work queue monitor's name?
That's good.
And in terms of the scheduling appointment books, this is where the clerk will be scheduling the patients for their appointments. And so for the book itself, it's called RHS Colposcopy book. And then the resource are the providers as well as the examination room. Further scheduling details will be validated during the validation with Donna, which is to be coming up October the 17th. Has Milena joined us yet? Okay, don't see her.
Sandy, if you have a chance, if you can grab Milena, that'll be good. But if she's busy, then I think it's okay for now.
All right, I'll just check. Hang on, give me a minute.
Thank you, Sandy.
We can also validate this during the validation session as well, during the scheduling validation session. Is it okay if I continue forward, Sandy?
I think Sandy just stepped up for a second to grab Milena. If you
Okay.
can just give her a minute or two.
Sure. Thank you. Jonathan, are you in the same room as Sandy?
No, I'm not.
Oh, okay.
I see Milena is joined.
Perfect.
Now, it's Sandy here. October 17th, I won't be available. I'm on vacation. Will you need me or someone to cover? Or will Milena be okay for that?
Donna, would you be able to speak to that? Sorry, Donna, if you're speaking, we can't hear you.
I'm sorry, I was on mute. Yeah, I think that would be fine. Jonathan, are you able to attend on October 17th?
Yeah, so between Mary, myself, and Milena, I think we will be there. So it should be okay, Sandy. Because I think this speaks more to the scheduling pieces.
Yes.
Perfect.
Thank you.
Thank you.
So Milena, thank you for joining. We just want, so to catch you up to speed, this is the scheduling appointment book. So within the Sketch app book, this is where you will schedule patients' appointments and also list out the resource for the clinic. So for the book and the bookshelf itself, it is called RHS Colposcopy Clinic.
Thank you for the update there.
Thank you. And the resources we have are the provider and the colposcopy examine room. Is that satisfactory to the clinic?
So which part, the satisfactory, that the understanding of it or how it looks, or?
Yeah, the name of the book itself and
Looks,
the resources. Oops.
yeah, looks fine to me.
Okay. There will be a more in-depth scheduling validation session that we're just discussing that is scheduled for October 17th with Donna.
Okay, thank you.
So I'm just gonna pause here. Does the clinic have any questions regarding just what was discussed? Or any questions in general? Okay. I hear none. Okay, so we're gonna go through the colposcopy workflow here.
Oh, sorry, I
Uh,
did have a quick question. Hi, this is Milena here. So the other screen, when I will open the screen, will it automatically look like that, the double screen where on the bottom I can already see what's scheduled? Or is it just for an example for us right now?
And once you open this book and you have the patient ready to be scheduled, this actually shows right underneath the bookshelf, which I can show in a moment.
Okay, thank you.
Is there anything else from the team that a CST team they would like to add? Okay. So going with the referral triage workflow here. So we understand that this clinic receive referrals that are for direct booking, where there's no referral triage required. So such example would be coming from the BC Cancer Agency, where they will send a slate to the clinic for booking, or it will be a guide provider that will place the order and go into in the queue, and the clerk will then schedule these types of patients as a pre-outpatient encounter as opposed to a triage encounter. So it bypasses the triage process.
There's also a third option though that I do not see here. These both are the ones that would have Cerner. There is numerous referrals that come in from other doctors' offices that would need to be uploaded and scanned that would not use Cerner. So there's quite a high volume of those as well. And especially now that in September they're starting the screening program, there will also be I'm predicting a high volume of referrals from family doctors' offices after the patient does their own screening and has some sort of abnormality.
Right, that is a good point. Milena, are you referring the referral from GP offices that, like you said, doesn't have Cerner access, and they'll be faxing those referrals into the clinic?
That is correct. And we do have a high volume of that now, but I'm really thinking that as of now, because this new screening program for PAPs that the patient does themselves has just started, and I think that we're going to have an influx from family doctors.
Thank you for your question, because it leads right to our next slide. The referral that you just mentioned in Cerner, we call those external referral. Like you said, these are the providers that are not on Cerner, where they will need to fax in their requisitions to the clinic. Okay, so there is the external work. So this is the workflow, overarching workflow for referrals that needs to be triaged, and it could come in from external orders or externally, like from a family doctor, or internal, so within Richmond Clinic or, within the Richmond Hospital. Okay, and so for the external order, they will go through what we call the work queue monitor, hyphen as WQM. We will receive those. Then the clerk will need to create a scheduling request and then creates the referral encounter. The patient is placed on a triage list in the Sketch app book. And then we will import documents, or what we call index the referral from the work queue monitor into the referral triage encounter. And if it's an internal order that comes through, it will be received electronically in the Sketch app book. Then we bypass the work queue monitor. We just need to create a referral encounter and place that on the triage list in the Sketch app book. Hi, Dr. Robson, you have a question?
Yeah, so what exactly is an internal order then? Because it seems like does that mean some things that are sent into the clinic will appear as if you have the right referral, or is that something that's like within the hospital? Because most of these referrals would come externally, or I don't know, is internal the ones that would come from BC Cancer because it's also on Cerner? They would be considered internal, and the ones from people's offices would be external.
I can
Because
I can answer the question. It's Jordana. So internal, we refer to that means they have access to Cerner. So, and yes, anyone who's internal to CST could place the order. We don't believe the BC Cancer ones because they usually send you a slate. They're not sending them one at a time, right? If we ever changed the process where they sent them in one at a time as orders and it was direct, but I think because they come from an office that sort of they're coordinating all of those, we don't, those won't come in as what we call internal. Internal would be like you know, an ambulatory clinic within any of one of the Cerner hospitals sends in an order. And so you're right, most of them won't, and we know that, but we do have to account if the odd one comes in internally.
okay, because yeah, I just, as long as there's the understanding that most of these are going to be external, because if well, and I don't know how the ones come from the cancer agency. And I guess Milena will know that answer to that probably, because they are sent like as they come up, are they not, rather than as a bundle?
So they are sent. I'm not quite sure what you mean. So they're sent. They see an abnormal result, they automatically send it to the colposcopy clinic. But what sometimes
They don't
happens
send
is,
a slate of them, right? They send each individual patient
correct.
as soon as the patient has an abnormal.
That
Right,
is
but
correct.
because
Yeah.
but I think right now they're sending them as like how they received them, so they're also sort of paper. They're not like generated because someone entered them
Right.
as an order. So that's what I'm saying. So they'll come in the same way they were, which will be by fax. And now that we're getting rid of the fax machine, it'll be called work queue monitor. So they'll just come in, you know, as an electronic mail, if you think about it like that. But you're right, there we don't expect many to place any internally, but we do have to account for it. And you know, I don't know if some point some private physician offices eventually come on to Cerner, that would be, you know, that would be how it would be done. But right now we expect most of your things will come in via work queue monitor, which is your electronic fax.
Okay. So carrying on the process here, the triage, so Dr. Robson and Dr. McDonald, O'Connell will triage the patients in referral management and happy path when the order is accepted. Then the clerk will check the accept order in patient management office to see the status has been changed to accepted. Review the scheduling instruction from the triager. I'll find a patient on the triage list and then schedule an appointment. And they will do so also by changing the referral encounter to a pre-outpatient encounter. And move the patient from the triage list to the waiting list and schedule a book and update any permanent details in the appointments. Any questions about that workflow?
Oh, hi, it's Helen again. Just in terms of when we triage the referrals to the clinic, often it's fairly straightforward. It's, you know, X number of weeks that we say the patient needs to be seen by. However, sometimes there are like incomplete, like, or ones we can't make a determination because they don't come with enough information. So would they then be like rejected, but with a, like, is there a way of putting a caveat on those? We need more information. We need, because we would normally just write that on now. You know, we can't book because we don't have the pap smear or we don't have enough clinical detail. How would we, is that a rejection or is that an exception with caveats on them? Like, how does that look?
Yeah, good question. So Dr. Robson, there would be a order, a third order, along with rejected referral call request for more information. Will instruct the clerk to request more information from the referring provider to provide what is missing. Okay. Any other questions from the clinic about this workflow? All right. Next, we'll talk about the gynae colposcopy order and the gynae leap order. Robin, if you're ready, can I ask
Yep.
you to unmute yourself?
Yep, I'm here. I'm gonna take control in just 1 second, but Dr. Robson, thank you kindly for sending your clinical indications back to us. And what that means is in the event that the internal order is used, it would fill in the spot marked clinical indications highlighted in the red box, and you can see on the bottom there's like a drop down, and that's what we were looking to kind of pull in there, the appropriate indications for colposcopy and LEAP. We did get a couple from VGH, so we have their input, which will kind of collate with the items that you have requested. But I just had a couple of quick questions on the ones you sent me. So I'm gonna just share my screen for a quick sec.
And obviously there should be, and in addition to those, I guess there should be sort of an other, because
Yes,
it's gonna be the
yes.
potential. And I did send it to Dr. O'Connell. I didn't see if she had reviewed it or added anything to it.
Not to date. I haven't got anything back either, but if there is, we can always, make an update. And yes, we do put the other in as well. So what I wanted to show you was this little grid that I made. I took the items that you gave me over here on the left-hand side, just kind of alpha sorted them. And then, oops, apologies, went too far. And then the green ones here were the ones that VGH had requested. And I wanted to see, one, we have a 40 character limit, otherwise you won't be able to like read it on the screen here. So I did kind of my best of narrowing it down, and I wanted to make certain that it was acceptable to you, to look at what was here to what is here to fit the character limits.
Oh, absolutely. I just wrote it out so that it would be
Sure.
like, it's fine from our perspective to have
The
to
abbreviations are okay.
abbreviations. Yeah, it just
Perfect.
using even just the ones in the brackets is fine. I just wanted to make sure it was clear what.
Sure. No,
Um,
that makes sense. Yeah, I was able to get them down under 40 here, as you can see. But then my second quick question is then, let me scroll this over so you can see it. Are all of these applicable to both the Colpo and the LEAP, or would there be some that are not applicable to the other?
no, LEAP would usually be, so basically these are mostly reasons, because sorry, I had taken from it, you wanted the reasons for colposcopy. So these are
Yes.
really the reasons to do colposcopy
Sure.
rather than the reasons to do a LEAP, which are based on pathology, like tissue diagnosis usually, rather than to do like based on a cytology diagnosis, which is what these are.
Okay, so what I'm gonna do is leave these all here underneath the colposcopy order. This is what we currently have for the LEAP, and your suggestion here seems to be the same one that VGH had, is that if that's acceptable to you as well.
Exactly.
If there, Mhm.
That would be, I mean, that's pretty much the same, like, so a LEAP, I guess they're saying, yeah, because I mean that you're not, that's tricky, because post-LEAP follow-up, you're not doing a LEAP, you're just doing a colposcopy. So the reasons to do LEAP are like those are separate. I
Okay,
guess
so you'd like one to say, like basically LEAP 4 to 6 month follow-up after LEAP procedure.
Well, the 4 to 6 month follow-up post-LEAP is really a colposcopy request, not like if this is supposed to divide what's a colposcopy request versus from what a LEAP request is, then you're doing LEAP. LEAP is really done either for diagnosis or for treatment. And for diagnosis, there are some categories for LEAP, and then for treatment, it would be like, you know, usually it's CIN2 or CIN3 or AIS would be the main ones, but then there's ones where you have like CIN1 with unsatisfactory colposcopy, or sometimes you might do it for persistent postcoital bleeding or something like that. So do they need to be that specific? Because I can send you a list of those too.
It's whatever you most commonly write. Like, so if you were to write an order for a colposcopy, like to have it booked, and you know, your indication would be, I'm assuming you're picking from your list here that you have marked for colposcopy. But now if you say, you know what, we need to do a LEAP, you're going to pick the GYN LEAP order. Well, your indication, whatever you would normally write there, it's basically us just trying to help you from typing.
Okay, so yeah, I can, so that, yeah, the post-LEAP follow-up doesn't really, it's a colposcopy. It's not
Okay.
an actual LEAP. So I don't think that belongs there.
Okay.
Yeah, I can send you a list of what belongs there if you like.
Sure. Yep, whatever works for you, because I'd like to just try to help you, so that way when you're you know, like in this box down here, you can just pick from your, you know, your, like you have here, kind of 10 or 12 common ones versus typing.
Okay, yeah, that makes sense.
Okay, great.
So some of them might be similar, same, but normally,
Sure.
yeah, we would be doing it for CIN as opposed to these atypicals are more the pap smear diagnosis, whereas the LEAP is usually done due to a tissue diagnosis. So I can add those in. Yeah, and I guess if we add an other category, then that I guess could be then either just under other, or if it can be expanded to say why you're doing it, that would be great.
Yes, you'll have the opportunity to add in any additional information in the box down here as well. So
Sorry,
I'll just,
Milena, can I just quickly ask a question? So right now we use post-LEAP follow-up as when I book. So Dr. Robson, would you be okay if I have a post-LEAP follow-up as one of the drop-down options to use? So so we know it's a colposcopy, but that it's a return patient coming back?
Yeah, absolutely. It shouldn't be in the LEAP column. It should be in the colposcopy column, right? Because you're booking them for colposcopy, not booking them for LEAP, and that's
correct.
Confusing otherwise for you to be looking at that and going, oh, I have to find that in the LEAP section, when really it's an indication for colposcopy. And sorry, I misunderstood. I thought you just wanted the indications for colposcopy.
no problem. It's totally no problem. I can just wait to hear back from you for if you'd like anything here. And again, like I said, we can always add to if you don't happen to get to it, you know, in the near future.
Yeah, I can probably do that. You know, even like it won't take very long because it's a much smaller list. Okay. Now, sorry, you said these are what VGH has for their colposcopy indications.
So VGH just took it from their form. They just had like those check boxes on their current form. That's all they wanted to add into theirs.
I have a couple more that I would suggest. So I see they're low grade. So the ones that we get here, the 3 from the cancer agency, some will say low grade, some will say high grade. And then there's also a third option. I'm just gonna see quickly what there's atypical, low grade, and high grade. Those are the 3 how I have mine separated now from the diagnosis, but I only see low grade here.
Oh, that I think there's
high
some
grade
high grade
is there.
here.
Thanks. Thank you. High grade.
You're welcome.
Okay.
So there should be, so low grade, there's also atypical, so there's ASCA, so there should be both. So ASCAs and low grade are pretty much the same. I'm probably putting ELSO just under ASCAs would probably be a better place.
You know what I can do? I can just send you this grid if you like, just in the same format you see it here. Like, so you can list what you would like to see under the COPO, the indications, and you can list exactly what you'd like to see under the LEAP indication.
Okay, that'd be great, because I would like to run it past Jacqueline as well, because because I'm not going to be doing colposcopy for ever, and she's going to be doing it for longer in the future than I am. So it might be, and like, because the one that says follow-up precancer change of the cervix CIN2-3, that is only in women who are under 25. So there is, so that was, I know that was probably a longer, but I would say that could be shortened to like follow-up CIN2-3 less than 25 years or something like that to be made. See,
I will send this back to you, and it'll even have these little counters here. So as you type, you'll see exactly how many characters you've got in there. So and when you are able to get it back to us, please just send it back to Karen and Mary, and they'll forward it on to me.
Okay, sounds good. Yeah, now I know kind of what I'm looking for. I think I mean, we could even just do it the way VGH has, but I think it would be kind of nicer to have a little bit more specific information.
You can definitely have whatever you'd like here, just knowing that the more you have, sometimes you'll end up scrolling. So, you know, if you have like maybe your 80-20 rule where whatever you're typing 80% of the time there versus, you know, those smaller incidences, then you can use the other option and type those lesser frequent indications.
Okay, sounds good.
Okay.
So can we put it in from like the most frequent to least frequent in terms of, so the top ones will be the most?
It actually alpha sorts them, so it'll just be alphabetical as you see.
So okay.
Yep. Okay, thank you so much. I will send it back to you, Mary.
I guess, Mary, before you start over, I just have a question. I know this is Donna from scheduling. So in previous meetings, we discussed that when we schedule the LEAP, we're going to automatically schedule the follow-up for 6 months. Should that follow-up be a colposcopy follow-up or a LEAP follow-up order?
It should be a colposcopy follow-up.
Okay.
Because they're having, you don't get a LEAP again unless you have an abnormality of your cervix at that follow-up. The follow-up for LEAP is colposcopy.
Okay, great. Well, I'll make that change in the test system so that way we can show that in the scheduling validation session.
I think that would be right, although I don't know why VGH seems to have it they seem to have it on the LEAP side rather than the colposcopy side, unless it's easier to categorize it if it's like that post-LEAP follow-up would be part of the LEAP system.
It's your order indicating what you're going to do, and it links to the appointment, and it will tell the nurses what the patient's coming in for. So if you don't think it's appropriate, then
so it should be colposcopy, I think, since that is what they're coming for. They're not coming for another LEAP.
And is it always a colpo, or would there be incidents where you would say, no, what, this patient's going to get a second LEAP?
No, that would be ordered. Like, for example, if you have adenocarcinoma in situ and your margin is positive, they're going to have a LEAP right away. But that would be sort of an exceptional thing. Most other people are going to come in for follow-up and have a colposcopy done, and a discussion about further LEAP would be just based on their pathology. So that adenocarcinoma in situ is the only situation where a second LEAP might be done without a colposcopy in between.
Because what Donna's stating is they have it kind of built out, so that way when you do a LEAP the first time, it's automatically going to book a colpo in 4 to 6 months.
Yes, exactly.
Okay.
Now, whether that's 4 months or 6 months, is likely going to be based on margins. But most of the time it's 6 months for follow-up. Obviously, there'll be exceptions to that. And that will depend on pathology, but I assume that just can be sorted out and ordered on the non-routine side of things. right? If they've
Yeah.
had their appointment booked in 6 months, but you need it to be done in
So-
2 months or something, like they have to have another leap, we would just send a request in for a leap rather than for a colposcopy.
Okay, so that's why I'm questioning, like, because it's basically gonna automatically trigger the clerk to book that second one. I guess, Donna, maybe it shouldn't auto trigger that, maybe because it sounds like there's some clinical input that's required as to when even the colpo would be ordered, versus, and it could be a leap.
90% of the time, it's going to just be a 6-month colposcopy. So
Okay.
if that's easier to generate that as the norm, then the exceptions could just be determined and ordered.
Okay.
And even if, for example, somebody needed a repeat leap in 2 months' time, they would still end up needing another colposcopy in 4 to 6 months after that anyway. So
Okay, all right, well, we'll let it go, and then if anything needs to be changed, we can always update.
Great, thank you both.
Okay, Mary, are you back?
Yes.
Okay, there you are, thanks.
Great, thank you. So next I will go through a external referral workflow. Okay, just gonna bear with me for a moment, share my screen. Okay, can everyone see my screen okay?
Yeah.
Yes.
I apologize, it is a bit squished, and that's because I am putting 2 applications into one screen. But when you are using Cerner, you would have the dual monitor, so it'll look a little bit bigger. So on the right, I have the scheduling appointment book. So as I said earlier, this would be the application that the clerk will use to book appointments for patients. And to my left, this is what we call the work queue monitor, or WQM. And that is where we will use, we'll see the incoming fax for patients or any kind of forms that are being faxed to the new dedicated colposcopy clinic. So you can see here at the top that there is tabs for different queue. For now, we are going to use the unknown queue, but in the future, this queue will be called the RHS colposcopy. Okay. And so the clerk will monitor the work queue monitor, and when they see a document come through, for example, a referral form, they'll look through the information. They will see the patient's name. And once they see that in the second monitor, they can go to the appointment tab in their scheduling appointment book. And we'll fill out the information. Now, this first step is called creating a scheduling request. And so to create a scheduling request, we'll put in the location, RHS colposcopy. And the
I have a quick question for you. Sorry to interrupt there. So once we do that and we enter RHS colposcopy, will it auto-populate it after? So it's in memory. So there's less for us to type as we go along with the high volume.
That is a good question. So I know you can't see when I was typing, but all I did was RHS col and I hit enter, and then the computer auto-filled the rest of it. So
Yeah, and Mary, this is Donna. There are user preferences that she will be able to set and default her location to colposcopy.
Okay.
And for the appointment type here, so this is the new referral. I'm going to select the colposcopy new patient. And then now it'll prompt me to bring up the patient's name. So I'm going to type colposcopy. And this 3 dot here will allow you to do a search. Okay. Searching for a patient. Oh, excuse me here. Sometimes the screen escaped me. Okay. So we have the patient's name here, and just keep scrolling down. And reason for visit, so that will be transcribed from the referral form. Ordering provider, that will also be collected from the referral form. Okay. So for testing purpose, I'll just put in the test provider's name, referral date. So you just look, referral receipt date. Just look at the queue. You can see it was received yesterday. So a shortcut, I can do Shift T for today and then hit down for the day before. Priority. Just transcribing it from the referral order. So they say next appointments available, and if they require interpreter or not. Okay, scroll down. Any scheduling comments that may be in the referral order form. Any questions up until this point? Okay. So I move it into the work in progress side. And there will be an appointment attribute that comes up. Just want to indicate that this is an in-clinic booking. And the clinical indication, that was just what was discussed between Robin and Dr. Robson. This list will be shortened, customized. We'll just click that. So here I have created the appointment attribute as in work in progress. And then we're going to go under the booking here.
Sorry, it's Helen Robson again. I have just a question. So that list that you have, is that list really for filling in this form more, or is it more for filling in the like our part of the form, or does it not matter? Or is it like for both? Because as I say, it's a fairly like detailed numbers, whereas I see that VGH1 is not so detailed, and maybe that's the reason. If it's just like colposcopy follow-up, LEAP follow-up, and colposcopy new visit or whatever, that is probably detailed enough just for Milena to be filling out. She doesn't really want to necessarily fill out like all the nitty-gritty details. So I guess that's the question, is that more for this form, or because our form, we would fill out the more detailed part of it, like as long as there's somewhere to fill out the more detailed part, which would normally be on the colposcopy form anyway, then if it's just a scheduling request, it doesn't have to be as detailed.
So it's
I agree.
So it's a little bit more than just a scheduling request. It is both a schedule request and your physician order. So the workflow she's showing right now is if somebody who does not have access to CST Cerner is sending it in. She's transcribing what is written on the requisition into both the appointment, but also it's going to generate an order that will be placed on the patient's chart, which is linked to the appointment. If it was the reverse, where somebody who has CST access like yourself, and you're going to order an initial or a follow-up or whatever it might be, it's for you to indicate your clinical order, but then also your schedule request. So it's kind of a twofold list. So
Right,
I
but
think
it's
you
not-
can make it as detailed or as not as detailed as you guys would like. And if you document that in some other place, that's, you know, I think whatever's required for your order and for the booking.
But it's more, this is more about the ordering and the booking rather than the actual colposcopy itself, right? Because
Yeah.
so I guess I may have been misinterpreting that, and that may be much more detailed than we require for just booking. Because really for booking, you want to know, is it a new visit? Is it a follow-up? Is it a leap follow-up? So I guess more like that information that VGH had on theirs, if it's what the clerk is putting into the system, rather than it being the decision making about when a colposcopy should be booked, or actually saying what a colposcopy is actually for. Which I mean, we put that normally on the colposcopy form, and I'm assuming that doesn't populate from that list. The colposcopy form will be filled out all on its own.
Yeah, so this is the indications list that you were providing to me, Robin, that's the list for your diagnostic like order or your requisition, that would be indicating the patient needs to come for one, and then, you know, I guess why they're coming for one. So I will provide you that list, and you can let us know how detailed you'd like to be in that.
Right, because I think from a just a booking point of view, the categories do not have to be as specific as they will be from when the patient's there and you're analyzing
your
what
documents.
happened.
Yeah.
As long as we can, and as long as Dr. O'Connell and I can access the reason they need to come, that will give us the timeline in which we will book them for. But that doesn't necessarily I assume we're not necessarily filling out the reason why they're coming either. I think, I guess we could have the kind of basic headings maybe in the beginning, and we could like scroll down to more specific headings if we wanted to. I suppose that might make it easier, because it's just not really fair to Milena to have a million options to choose from when she really only needs to know if they're coming for a new visit or a follow-up visit.
Sure. I'm
Thank
sending
you.
this list back to you, and you can send it back to me however you best see fit.
Sorry, it's Jordana. Can I just make sure we're clear on, there's sort of two parts, the order, which is what the physician writes of what test they want, and they're communicating it to yourself because you're referral triaging it. You're going to, you know, decide when you want to have it. So that information that Robin has shown you is what you need to make your clinical decisions. It also is going to print out when the patient checks in. It's going to be given to the nurse. Or the nurse can look it up electronically as well, in ambulatory organizer, and see what's happening, what patients coming in, why are they coming in. So I would caution you making it very clerical focused, because it's what you need to make your triage. It's what the nurse needs, and, you know, to set up and get ready for the patient and understand why the patient's there. Same with yourself, because you're going to have done this, maybe 6 months before, and now the patient's back. What is this patient actually here for? So it is all the clinical indications. The part that we see here that Mario is demoing is transcribing that information into the computer. So the appointment is booked one, but also so that we don't necessarily have to look at the original requisition if we don't need to. But, you know, if there's a lot of handwriting on that original requisition, the clerk can just say, see original requisition. We don't have to transcribe everything. I mean, then you would go back in the system and look at the original requisition. So I don't know if that helps you, but just think of the order as what you would place as if you're placing an ECG, an MRI, what clinical information. It's really the true order is for the physician and the nurse and whoever's doing the procedure to know what to do. It isn't really from a scheduling perspective. The scheduling is when you go in and triage it and you accept it. You say, I want to book it in 6 months, or I want to book it in 3 weeks. That's where you're giving the clerical information about the appointment type.
Okay. So more detail might be helpful from that point of view. Okay.
Yeah.
But they can't look at the original order for the more details. I could
They
see.
can. They can.
Yeah.
That's what I'm trying to say. So I
Oh.
would think about the electronic order that we're building is in the future world if everyone was electronic, so you wouldn't have to transcribe it. Like ideally in the end state, we would never have to transcribe all these orders. It would be placed into Cerner, but it's not. So we kind of have to have this dual process in place.
Okay, but even if it's in place, did I miss something where I would not have to enter that much information? Because when you have a high volume and you only have one of me, I can, I appreciate Dr. Robson advocating because that would be a lot for me to enter.
So you can, sorry, Mary, can you just show the scheduling? So right here at the top of the appointment. So sorry, at the top there where you've got that, you've got person RH Colposcopy 2, appointment location, appointment type. Can you just scroll down there? So far, so reason for visit, just scroll up a little bit there. You can either write that information there. That's just copying what you see on the form if it's, very simple and short. And same when you click move, like the additional fields, those clinical indications, if you click move, I think it prompts you. You could say other as the option. Oh, sorry, maybe it didn't show. Donna, how do we get that window to pop up? The orders, the SAF, I think you call it.
Yeah, I'm sorry,
Right.
you're trying.
Just the appointment attributes. If you right click and find
Oh,
appointment
yeah.
attributes.
So here, again, see how it says clinical indication. Sorry, it's real small for me, but it says colposcopy as the drop down there, clinical indications.
Right.
You can choose colposcopy. You choose one of those if it's obvious, but usually in this, if you scroll down to the very bottom, there's usually well, maybe it's not in this list, but we can add it like an other. So and then you can write in the special instruction. So this list is pretty long, so that might be hard from a clerical perspective to find it, but see the special instructions just under research study right there. As long as you fill in the mandatory fields, you could say, please see original expression or, see original requisition. You're importing that requisition. We haven't got to that step, but when you import that requisition, it will be there. So you can point the physician to look at the original requisition so you don't have to transcribe everything. And we do that in cutover actually, because we don't actually import the requisition, but sometimes it's very easy to fill it out quickly because, the drop downs match exactly what was put on the paper. So, sometimes that's easier than writing, please see original requisition or whatever. So there's multiple options for you. You don't have to transcribe everything if you don't want to. You do have to do everywhere where there's a red asterisk.
Well,
Okay.
and also, could we change that? Like if the indication says colposcopy, which of course would be the indication, when we triage it, can we change that field to be like ask H or 6-month leap follow-up or whatever we see it as? I mean, I think it should be easy enough to put like new colposcopy, repeat colposcopy, leap follow-up as being, because those are kind of the 3 or clinical abnormality or something like that, which are the 4 main indicators of what we would see. And then if we are triaging the other requisitions, we could add in, like we could change it to a more specific thing if we're able to change that. But I'm not sure, ultimately, I'm not sure it seems to me in this spot, it might be fine to have it fairly like wide open in terms of what it is, just like it would be now, because I mean it does say on our sheets, it does say the patient's coming with a pap smear. I don't know how that's generated. I guess like on our normal sheet, it would say like the patient's name and the information, and then on the side it would say the referring physician, and it would say, LCIL, ask H, HCIL moderate, like those would be written there, and I don't know how they're generated. I guess it would be similar to put it in this spot. I guess that may be something that we need to maybe just look at.
It might be easier if we finish out to the referral management. You might get a better sense because we haven't got to that point. Then you can see what it looks like from a physician perspective, and maybe it'll, rather than us to sort of decide, let's finish it out, the demo.
Okay, sounds
I
good.
think it'll help.
Okay. Update this here. Go under requests. And so right now it's under the ambulatory colposcopy future request queue. I'm gonna remove this request from that queue and put it underneath the triage list. Okay. So that concludes the creating scheduling request step. And now I will go ahead and index or file this referral form into the patient's chart. And so to do that, just double click on that documentation. See here, there is no patient information, so I'll look for my patient here. Patient search. Click on okay. Okay, now you see the patient's name and their information has been populated onto this banner. We're gonna label this document type. And so for the colposcopy clinic, the shorthand to label this instead of typing all the words out is 11,500. One second here.
Mary, is it not a referral package?
There is one with the name that is colposcopy requisition form. And this is the code. I'm not sure why it's not coming up when I press that. 11,500. Let me just step out here and try again. Refresh the queue. Oh, yes. Okay, great. Document type 11,500. Okay. Seems like my connection is not.
Mary, just
Wait.
type requisition. Oh, you most definitely, yeah. There must be something going on today. Sorry, it's test domain. So
You might want to try the number again and then click on the ellipses. I think it'll probably give you the, oh,
Yeah, I think the number is 11504. Wait, I'm sorry, 11500. Is that what you have there?
Yes.
I wonder if you
There's
have
one other
your,
thing.
There you go.
Sorry,
You
is
have
it
it.
not working? Yeah, select that. Double click. Does it not work?
Okay. Somehow this was deselected. I'm not sure why. Okay, here we go. Okay. Sorry about that. So the number is 11,500 and should auto-populate. And if not, we'll just double check and make sure that this checkbox is checked, or else the form will not come up. All right. For this form here, because we're going to complete this from the work queue model, we'll put in complete. And then we will also add in the forming provider scanned documents. We refer petition, text Alex. And this is complete. Okay. Sign documents. Still giving me, not giving me the ability to type here. Sorry about that. Okay. Must have come off when I was playing with it. Okay. So referring provider will have it identified as a scanned document so that we know this document came through work queue monitor. Okay. And you see that the order, I'm sorry, the documentation drops off from the queue. Any questions about that?
So to get one fax that's coming from an external source, you have to go through how many windows to actually, and how long would you think it would take for just one booking for all the steps? I think I'm lost at this point from the time. So there seems to be like a lot of different windows and a lot of different steps just for one referral. There's no way to like amalgamate some of the steps to make it more efficient in any way.
Well, earlier it was just the, I think there was a slight glitch with the indexing of the documentation. But once you've gone through it a few times, it's actually quite straightforward in indexing these forms to the patient's chart in Cerner.
Okay, because I think maybe we'll just need to go through the steps again, because once you receive it, you have to put it in one place. Then you have to enter it into a different, now that's a third. But there's no way to kind of, well, maybe I'll have to see it again then, because at this point, it seems like there's a lot of steps just for one booking for an external source. And there's a lot of like red asterisks where there's a lot of mandatory steps as opposed to just using where it says other and see the actual document. There's no steps that can maybe be omitted to get to this point at all. Like, is there a more efficient way of maybe creating this?
Okay. Jonna, would you be able to help? Is there anything that can be customized?
Yeah, so I guess to address it, once, and Milena will show you this again in the scheduling validation session, but it is a two-step process. So you would index the fax that is coming in, and then you would also go into scheduling and create that request. To answer your question, there isn't a way for us to automate when the fax comes in to automatically put that request in the scheduling application. But I think once we go over it again in the scheduling session, then maybe, right now we had a couple of challenges with the item not popping up for Mary, but we'll try to practice that and make sure that we get that seamless for you when we're doing it in the validation, in the scheduling validation.
Okay, maybe it'll seem a little more clear.
Yeah.
Because at this point, it looks like there's a lot of different steps just for one referral. When you have hundreds coming in, it can get overwhelming.
Yes, and I agree with that. And I think once you feel comfortable with it, you'll have, a better understanding of how it's going to flow. I think it'll be okay for you. But again, let's discuss it in our scheduling session. And unfortunately, there isn't with the enterprise configuration a way to automatically create that request. But I think if we kind of practice that and go through it with you, you'll see, you'll get used to indexing those faxes and then creating that request.
Okay, thanks for that.
You're welcome. And Mary, did you have a question?
Yes, I'm just really wondering how this is going to work because our site ambulatory care has more clinics involved. So I do appreciate the time of the clerks, and it is right. We do get about not just that clinic, but many clinics that they're in charge of. So I guess my question would be the same as Milena, and it's been answered. There's no other efficient way to make this more streamlined and more straightforward. So I think what we're going to have to do is support the clerks with that transition, because right now our initial start or end to putting in a case in the system, it's literally maybe not even 2 minutes. So it's a quick thing, or even less, where we just reference that way. So I think it's a process change in a flow change that we have to adapt to. But at the same time, if there's any way that CST or Cerner can make it more efficient, I think that's the part where we're appreciating that, because I guess going from something so simple to many complicated click, click, click here that we can see at right now versus what we'll probably be in 3 months into it, we'll probably understand and be more used to it. So I'm just trying to make sure that you guys have that clear understanding that, we're trying to work with what CST is bringing. At the same time, if you guys can also appreciate the time that goes into putting that in, and if there is any type of efficiency that can be supported, that would be greatly appreciated. And I think moving forward, if it's possible to have those glitches not be presented while we're doing this, because I do appreciate Dr. Robson's time and when she's on, and also the clerk's time, because we have a whole flow of clinics running. So just moving forward from that would be great. Thank you.
You're welcome. And definitely noted. So, and we can take that back just to, express that if there is any automation in the future, that would be something that we would be interested in. Thank you both. Mary, I will turn it back to you.
Thank you, Donna. Okay, so next what we'll do is the referral package has been indexed. We'll go in as the provider here, and we will triage the patient. Okay. Bring the referral management up here. So under referral management, for the provider, they can have this set in the system. Under the RHS colposcopy clinic, referral status will be ready for triage, and medical service will be gynecology. And they will run this filter to bring a list of patients that is ready to be triaged. And so for the purpose of this demo here, I'll be using the VGH colposcopy clinic, just because that one is what we have built at the moment. Colposcopy. Run. And then our patient here.
Hi, it's Sandy. I have a question. So this is what's been entered into our triage, so to speak. So if we see something abnormal, like the 90-year-old male, how do you take them off of it? Because that referral wouldn't really be appropriate for our department.
Right. Good eye, Sandy. That was more, I was testing the system. So this order wouldn't be placed for triaging in first
Yep.
place.
Andy, that would then be part of the triaging. If there's something that got moved into the triaging list or got referred to, and then that would be part of the review and triaging by the provider to say that this is not appropriate for colposcopy, if that is the case. But you're right, it probably wouldn't happen as a referral for a 90-year-old for colposcopy. It's just part of the testing. But if there is an inappropriate referral that happened and got placed into triage here, then that would be where Dr. Robson would say rejected, and for whatever reason that may be.
Thank you. Any other questions? Okay. So I'm gonna go ahead and triage the VGH gynae patient, patient 1. Here we have the provider view with the M page. We're gonna use the referral triage tab. And this is where you can see the patient's information. You can put in a new order, any documentation that might have been scanned. So this is where you will also find the referral documentation or the requisitions. I just want to show you, this is where we can put our accept referral order. And then also the reject order. And the request for more info. And these can all be personalized by putting them as your favorite. So once we have the order, we can go into our checkout. Let's take a look in the modified details. So earlier, Dr. Robson, you asked if there is some information missing. What can we do? So this is the order we would put in and require information. So missing info. And then you would go ahead and sign the order. Then for the rejected referral, you can select the reason for denial and put in any special information that will be also can be seen by the clerk. And then if we are accepting the referral, then we would set the priority. So this is the priority booking that the clerk will see based on the referral provider's instruction. Sign. And so you can see that the orders has been put in, rejected, be accepted, and then request for more information. Any questions from the clinic? Okay, so once the accept referral order has been inputted by the provider, then the clerk can go into the PM office or the patient's management. And then we would go under the work list, referral encounter work list. And then you see this rejection order. Robin, can you help me check to see where is the accept order in this queue?
Sorry, Barry, there's no accept order in this queue. You marked it rejected. Somebody put in the order for rejected. See how the referral status in column 4 says rejected?
Right.
So whatever is placed here, if it says accepted, rejected, or request more information, that's what's gonna update in the clerk's queue, who's monitoring the referral triage items. And then they can action accordingly, whatever is being requested.
Robin, sorry, I thought we simulated, if she went to the UBC bladder, there's an accept order there, or was it, sorry, a different one?
No, it's actually in the VGH Colpo order catalog. It's not built out yet for RHS, so for Richmond.
Oh,
It
I see,
will
but she
be.
priced the rejection one, so.
Yeah, but she placed a reject, so it automatically updated the referral status for this patient. So again, had it been an accept, it would say accepted, and then they can convert to a pre-outpatient encounter and book, or if you waitlist patients, you can waitlist.
Okay. Okay. When the referral status is updated to accept, then the clerk will go into making a referral encounter updated to as pre-outpatient, and they'll schedule the appointment in the Sketch app book, which will be demonstrated in the validation session with Donna. Any questions regarding to the scheduling part?
Sorry, Mary, can you just go back to the referral triage piece? To the referral management. So, can you make the screen bigger here? So when you open the patient, sorry, did you show all the order details? I just wanted to make sure that was clear for Dr. Robson. Sorry, where's the order? Can you click on the order profile one? So you see when you click on that order gynae one, if you click on that, the one, the top one, the gynae one there. So you see on the right hand side there, Dr. Robson and everyone else, that is where the order details are. So if it's not all filled in by the clerk, then that would be sort of limited. If that's the case, then you can go back and click on documents, which is on the left hand side, just above order profile here. And now this is a different, we don't have the original requisition, but if we sort of pretended that MOCA document there was the original document, it would be here and you would see the original requisition there. So it's just two different ways of looking at the information that's in the system, and that is where you would decide, accept. So you can close that. And I don't know if you showed the order. Can we just place an accept order? So you would stay there on the new order entry. If you just stay, okay. You can do everything kind of one-stop shopping. You just click new order entry. You can also have your favorite, so you don't even have to type it, but you'd have your accept. Now it doesn't exist for this particular encounter, but you would click the accept order at that point from there. And I think Robin, the orders look the same, right? It's just the name of the order looks different, because I just wanted to show Dr. Robson the fields.
Actually, no, there's this one's
fields.
very clinic specific, so it had different information on it.
Is there another patient she could show the accept order?
Because I think we have to be able to see we'd have to be able to see that referral information before accepting or rejecting. So as long as that's simple to find, you said that's in the documents, you'd be able to access the original referral.
Yeah, do you have the one that you scanned?
Yeah.
Yeah. That would be the original one.
Okay, but you have to
So
click.
that's right. So so you see the offset is the physician has a little more work or the clerk has a little more work. It's one or the other, right? Unfortunately. But you can always see the original if you want.
Yeah, I think we'd probably have to look at the original anyway in order to be sure of what we were, like how urgent it was. And
well, all of that should be transcribed. I mean, I think part of the problem is just our demos is not, we had some glitches and stuff. I think if we were to walk through it sort of more quickly and then sort of reassured you that it does, I mean, it definitely does take some time. You're transcribing something. But it does, if the order fields are like Robin showed you with the drop downs, and it's pretty easy. Most of our clinics are able to transcribe them so that, you are just looking at the one order. But again, we don't know, your clinic as well. And if there's lots of other things that are filled out, but generally speaking, if most people fill out the form, using one of those, it's just that the drop downs aren't on your form. So I guess that's the issue too. Like those reasons for exam, you told us, but they're not on your original form. So, again, the other option is to, maybe look at in the future, maybe updating this form to match what the other form is. So they're more identical. And so it would be easier to transcribe.
Yeah, because this doesn't have it, like it's supposed to have the reason for a colposcopy on there. That should be written in by the care provider. So they should be writing the reason why, and they should be attaching the pap smear, if the most recent pap smear, to the document as well. So it should be there, but that's you know, that may be a bit too much information to ask the clerk to be filling out.
Mm-hmm. And if that's the case, then that's okay. If you're going to be looking at multiple pages anyways, and you have to look at a scanned in result, then you're right. Then maybe we do lead them to making it looking more to the paper anyways. And that's how most of them are coming in, and so we could look at that to make it more simple for the clerk if we find them, because most of your requisitions are coming in from the outside. It's not like they're clinics that are going to be coming onto Cerner at any point soon.
So
maybe we
Jordana,
do keep it simpler.
sorry, it's Mary. So could you just change it now, like have that put through and change it?
Well, what we can do, I mean, I think we have to take it back, but I think what we could do, Robin, correct me if I'm wrong, but we would look at more adding other as some of the required fields so that the clerk can choose other. We still probably want to have the required fields in case someone enters in electronically, internally, even yourself. Because remember, if you enter the order for the follow-up visit, you enter the colposcopy order, the clerk doesn't have to transcribe anything. The order is ready to go. Right? Because I'm assuming you sometimes see the patient and then you decide they come back for another colposcopy, you're going to place the order. Is that right?
Well, that's a good question, because we haven't sort of got to that, how the orders are going to be written, like when we see the patient. And also the problem is that we have to look at the pathology before we make a decision there. And that's still a big, like, where do we, because right now medical records keeps the charts, and then they put the pathology into the charts, and then we go and we wait for the often HPV results, and then we go and we dictate a note to the provider to tell them what to do with the results. Obviously, it would be nice if we didn't have to dictate that note, if it could all be like on the form, which a lot of places don't dictate a note anyway, they just send the form. But we've had a lot of trouble with medical records in terms of their getting the pathology into the chart soon enough, and not losing charts on the way and that kind of thing. So if this allows us to do all of that follow-up from the colposcopy clinic itself, that would help us. I mean, then we could just say, okay, well, we schedule ourselves an hour of time to review the last week's colposcopy, or in light of the pathology, or 3 weeks ago, since that's what it takes HPV results to come back. And then we could put in an order for the patient to come. For example, the post-LEAP patients, it would be easy enough to put in, okay, we need them back in 6 months, and send that order, and then that could be booked, I guess.
Yeah, I think I mean, so we haven't really got to that part of the presentation, but yes, I think that's what we were thinking is once you fill out, I don't know, Karen, is it okay if we go to that M page now? The physician one?
I think we can. What we can also offer, I know there's been a lot of glitches in the demo here. So, and it's hard to see the end-to-end of this referral management, just like what Mary Escobar had mentioned. So what we can offer is maybe we can create a video that's a little bit more smoother from the work you monitor when Milena had to put it into the wait list and go through the referral management in a more smoother way. So then you can see it a bit more smoother than the glitches that you're seeing right now. So we apologize for that. So we can definitely send that to you and have more informal validation of that flow. So you can see that also, Dr. Robson, and how you can triage it a little bit better in that way.
Yeah, because it looks like a lot of data entry on the upside, and a lot of clicking of how do I find this thing, which obviously you want it to be as simple as possible, so that the you know, if you're using these drop down menus, you don't want to be having to search through a million things to find them, because that just becomes like so inefficient that it's, you know, it's not, that makes it all frustrating.
And
Absolutely.
also to keep mindful that the times that the providers are with the patient is really only timed 10 minutes, 15 minutes, or 20 minutes, depending on what type of procedure. So I guess going to that point, is it something that we have to look at extending, that we have to look at the workflow? Because normally you just get the paper and the provider has everything in front of them, and then they go ahead and check it. And we also ordered the old charts. So the old charts come and they review, which we'll continue doing it until it all goes paperless, sorry. So I think that's more of a high level conversation of just understanding the flow and making sure that we don't interrupt as much as the service, because Dr. Robson, Dr. O'Connell are very busy, and to take their time to do to search for certain things is not efficient at all. So like Karen said, if there is a video that you guys can present to just show us a better flow, I think that will help us understand. But it's overwhelming seeing all those lists when we click, and it's overwhelming to begin with. And I just want to make sure and emphasize that efficiency is really important for us, because it's a high-paced clinic and we don't want to rush patients. We don't want to take away the time from the provider, and we want to make sure we provide the best service for the patient. So I think I just want to emphasize on that, so that we're all on the same page, and we're going to try to see where we can support. I mean, there's going to be stuff that we're going to have to kind of negotiate with changing practice, but at the same time, if you guys can help us support with efficiency and making it more clear, especially for the clerk and the provider, or in the nurses too. Thank you.
It's Mary.
Sorry, do you want just to go to the Karen, the gynae, the M page that is for the interpretation, where they do where the links are?
Yeah, for the M page, for the colposcopy form, Jordana?
Yeah, just to show how that part works.
Yes. So Mary, are you okay to show that? Mary Chan, sorry.
Hi, okay. Sorry, I thought you were taking over, so I stopped sharing. Just one moment. Okay. So for those orders here, the plan is, let me just. Is to have those links in the provider's M page. And so the link will provide the colposcopy form and also the leak treatment form link. And that link will take you to the BC Cancer Agency form to fill out. Once that's filled out, once that is partially filled out, it can go into a shared drive for the clinic and update it as the information comes in.
Oh, sorry, maybe Mary, can you just go back to the Cerner for a second, just to put it in context. So I think what we were talking about, Dr. Robson, is you've seen the patient, you've done the procedure, now you're waiting for those results. You can start the document. No, I don't know if it's the nurse I think that's the nurse that possibly is starting the document, but that document, what we were in thinking is that you would click on that link, it would open your document, you'd fill it out electronically, and you'd save it to the network folder that we've created. Then first you would save it sort of locally, I guess, on your own folder. But when you're ready, when it's finally ready to be done, then you could store it onto what we call this network shared folder. And then once you've stored it, then again, and Mary Escobar, this is potentially where we might see a need for more clerical support, unless you have the nurses do this piece, but is the indexing of that result. And once we index that result, so I don't know, Mary, if you still have your work monitor open.
Yes. I do.
That's where we talked about at the beginning, where you would be here and you'd see the result, which is right there. And you just have to index it now to the chart and associate it to the patient. So you would say it belongs to, our patient was RHS Colposcopy, and then you choose the correct note type. And in that note type is called the, sorry, Mary's demoing it here for you. So you would just assign the person. And then you choose the document type, which would be colposcopy diagnostic study. So you see the one that says study, and then when you click OK, and there's I think the only other, there's two steps. You change the status to complete. And then I don't think it's there. It's actually below. Sorry, not that physician field. This one here, the provider field here, you would enter the physician that did the interpretation, which would be whoever that is. You enter the physician name, and then really, then the only other thing here is once you've done that, okay, good. You click the add button. Then you add one more physician here under the provider. Go back, Mary, to that provider field, and you would type in, and I apologize, I don't know the name, Karen, is. It's what is the BC Cancer?
It's the BCCA cervical screening program.
You add the cervical screening. I'm not sure in our build environment if we have that set up, but you basically would add that physician as a physician, if you will. And what that does is it sends a copy to the BC Cancer cervical screening. And then you could add anyone else. It already goes to the referring provider. It goes to the PCP, whoever's on the encounter. So, but this is getting rid of that faxing and all of that stuff that you're currently doing to send to all the different places for this form once it's complete. So that's what we've kind of helped, and we're hoping that will be faster for you and simplifies. I know there's a lot of times where that's gone missing.
Now, is this indexing happening after the provider has filled it out?
Yes.
And like right after, or are we waiting for the clinic to finish? Like what's the workflow that you guys are thinking we're doing this?
Whatever your current workflow, who is the last person to finish the form before it gets faxed to BC Cancer cervical screening?
Yeah, it's the provider. But
Right,
normally
so,
it just, but that at the end of the clinic, we get the copies. But we wouldn't be indexing at right after the procedure.
Well, I thought I know there's two forms, and I don't know the strategy around that, but one form you have to wait for the PAP and everything, right, before you send it off?
Both forms you have to wait for pathology. So if you scroll, if you can move that colposcopy form up, so like in this, like in number 2, for example, we would normally put in the reason for the colposcopy. So that might be, an H-cell pap smear or something.
Mm-hmm.
And then number 3 is number 3 and 4 on this form are what we do in the colposcopy clinic. So we will examine and we will say it's satisfactory or not, and what our impression is of the cervix, and then write in any comments that we have there. And then we wait for the pathology. And so then if you go down further, this part 5, 6, and 7 are based on the results of the pathology. So then we would fill out the results, which is the pathology. The final evaluation is what our decision is regarding the combination of our impression and our pathology results. And then we make a recommendation to the primary care provider, and that's where this is written in. Then we would sign the form, And then it would get sent both to the cancer agency and hopefully to the primary care provider, which.
Right,
medical-
so technically it's not being sent or indexed, if you will. We wouldn't index until you've done the final, like you've
Exactly.
got your results.
So we need to be able to fill the form out immediately, but that's just that the click boxes in the
Yeah.
top. Usually the nurse fills out number 1, which is their parity in their last menstrual period and whether they've had the HPV vaccination or not. So the area at the top left. And then we fill out 2 and 3 during the exam, and then 4, 5, and 2, 3, and 4 during the exam, and then 5, 6, and 7 are post exam, which can take anywhere between 1 and 3 weeks, depending on what results or even so if we do a pap smear, that could take up to 2 months to completely get all the information back.
Right, so our thought was, if we go back to Power Chart again, Mary, just where that links button was. So when you click on that link there, it would have your form. You'd click on your form. It opens another window, not within Cerner, which would be your file, that PDF file, if you will. So once you open that file, you would fill it all electronically. Now, this is if you want to do this, you would fill it out. So that sounds like it's in the room or just post procedure. You're filling out 2, 3, 4. Then you're going to save it into a folder on your, like, let's just say, I don't know if you want to call it preliminary or whatever, folder. When you get your final results, you go back, you find that file, you edit it, add your final remaining notes about the results. And then once you're finished and it's considered final, then the final step is you would go file, save as, and put it into the folder that we've now created, which is a lockdown folder. Once you place it there, it immediately goes into that work queue monitor. That's kind of what we were thinking. Does that make sense?
And that's when it gets faxed out, is when.
Yeah, electronically, yes. Indexed and faxed out.
Yep, that sounds good.
And so we're doing something similar at VGH. They just have they use their own system, so it's a little bit, but that's the same idea. They're going to index it and have it faxed out using the same process we showed you.
Right, and I think you said Lionsgate is still using a paper form.
They are, because once we get it working for you guys, we'll roll back to those sites and start them to ask them if they would like to do the same workflow. I mean, we might do that beforehand. Once we have everything set up in the system, we can also ask them if they would like to do it.
Yeah, no, I think obviously we'd prefer to get it going and have it right from the start. So I think that seems manageable. Obviously once we get, it does get a bit confusing the way, like this sort of clicking here and clicking there, and then it maybe not cooperating perhaps as well as it should be. That makes it a little bit more difficult to follow. I'm assuming if it's a more streamlined process, once we have it only with our stuff in it, or like with our the top, then hopefully that would come up more naturally. So yes, I think that's fine.
There's a question.
Hi, it's from Sandy. So what happens is when the patients come, they do a questionnaire, which is then we fill out that form based on the results of the questionnaire, like Dr. Robson said, was the section 1. But we also take that form back usually to also confirm what specimens have been done and confirm that everything was filled out before we send off the specimens. So, and then Dr. Robson, it goes into her room, or it usually goes into her after, so she can send off or send it to the lab, so they would fill it out. So that would be the final step. So that makes sense.
So it's kind of a shared form between nursing and the provider.
Yeah, that's what my understanding too. So whoever starts I guess like that sort of, you'd have to decide who's going to click on the link and open the form. And then, like I said, in your network folder, because it's not going to be within Cerner, you'll have to save it in a way that you can know you know, which patient it is, you know, like, like, it's hard for me to show you because we're in Cerner, but in your network, you know, when you save a document, like a Word document, you'd save it to a file, and then you would both have access to that file. So whoever is working on it, and maybe you save it with the MRN number so that it's obvious, like 7400293227 is the name of the file. I don't know, so that it's clear that's the patient you're working with, or, you know, you'd have to have some sort of naming convention that is very clear, and then that it started. And then, like I said, I would probably have a folder that would be called like, you know, BC Cancer cervical screening, preliminary files. And then the final one is the one that we've created for you, and you push it there when you're absolutely done and it's ready, so to be faxed.
So it's back in Cerner then at that point.
At that point, yes. As soon
Outside
as
of
but
Cerner.
you do have to move it to, like, physically move it, you know what I mean? Not physically, but like when you have to take it from the preliminary file folder and move it to this other one that we've created. And someone will have to do that.
Right. And then the paper form that the patient fills out, like we do often use that in our like, I guess, our interpretation of things. Well, can that just be then scanned into their chart and be part of their chart?
Yeah, so you have two options. You can fax it to yourself and it's immediately available. Again, would have to be indexed by your clerk, or if the turnaround time is sufficient, you can send it to medical records and have them scan it into the chart. Like, because I don't know, medical records is, let's say it's 48-hour turnaround time, you know, versus you know, if you want it more immediate. It depends how immediate you want access to it.
Well, I mean, I guess we'd have access to it if the patient's still filling it out on a piece of paper. We'd have access to it then, and then it could go wherever. Well, that's the thing, though. If most of this is going to be electronic now, then medical records would be, I mean, it would be nice to actually have medical records out of the loop of it completely, because they are the place where the mess up happens when we have trouble is with the chart medical records. So I guess our preference would be that the charts never were in medical records, that we could get all the information we needed without medical records being involved, because they're the delay and they're a bit of a problem for us.
Karen, you look like you're going to talk.
Just going back to what Sandy just mentioned, that I wanted to understand who would be the last person to actually complete the form, because I think there is that we need to identify who would be pushing this form to WorkQ Monitor for the clerks to be able to index it into the patient's chart.
That would be us. Like, we're the last person who
the
touches because we have to make the like put in those results and what the follow-up's going to be. We need to do that part. So it doesn't sound like it would be too difficult for us to then move it to the file, and then I don't know if there's a button that says, you know, fax to the list, then we can just fax it.
Sure,
I don't mind doing that. I mean, I do my own letters in the office, and I manage to fax them to the GPs that send the referral. Like, that seems to me not a huge deal, and that closes the loop, so we know that it's been sent, rather it being left as another job for somebody else to do. I see it as being reasonable and appropriate for us, unless there's something else clerically that has to be done to that chart. If it's finished with, which it should be, with the end of what we do, then it could just be moved and faxed, and that be like that. I think that's reasonable for that to be our responsibility.
Jordana, in the past, is there a way, as part of the provider training, to be able to do this? So then Dr. Robson and Dr. Connell will be able to understand what they need to do to be able to push it to work you monitor.
Well, are you saying, sorry, the saving the file is definitely the physician. It's the indexing of the chart that is currently done only by clerks or nurses, but not by physicians.
Someone, it needs to push it from the shared drive to work you monitor, correct?
Yeah, but that's just like I don't know, Mary, if you have a document open, that's just going file save as, and you just choose the network folder. Like like no, not in there, sorry. Just in any Word document. Do you have a Word or PowerPoint or something open? Oh, open your PowerPoint.
As long as there is a way that we can walk Dr. Robson to be able to do that during training, so then they'll understand what they need to do, or we can put it also in the workbook as well.
Yeah, no, but just here, Mary, just go file save as. That's just going file save as, and then you choose, you know, when you go, she has this PC, but instead of this PC, you choose a different directory. You know what I
Do
mean?
you want me to show them how to import the documentation into Working Monitor?
We already did that. That's the Working Monitor. This is the only step the physician has to do is file save as and put it. You when you go when you choose browse, just choose browse or something like that. You know, here instead of like you'd have a little network, see where it says network, that would say the name of the file. Like you'd have a G drive. It's like your G drive. You just click on the G drive. There you go. And you save it into the network. Like it would be called. That's it. Just click save. You don't have to do that for now, but I'm just saying that's all you would do. You can click cancel. As long as you're logged into the workstation, you're just saving it to a folder. As soon as that's done, it's already into Cerner.
But then from there, how does it end up getting?
That's this step. So this is the step here, right here, like Mary, if you just close the screen for a second. As soon as you've done that, you would click refresh here, and then the file would be right there. This is the indexing part, but this is normally done by a clerk or a nurse that has Reg Sketch access. I haven't seen it done yet by a physician, I don't think.
So
Then you have to do the
once
steps here.
so once we'd finished the chart, it would go into this file, and then it could just be faxed out. Like,
well, it's not faxed out per se. What they do is that step. So double click again. You have to find the patient. So we're basically, if you think about it, we're filing it into the chart, and the note type that we choose when we choose that cardiology colposcopy diagnostic study, that says fax it out. It knows that this note always gets faxed out. Like
so
it goes to Accelerus, it goes to Care Connect. It does a few things.
The question then would be like, who's doing that? Because currently who's going to do that? Because that's currently being done by medical records.
Well, we were hoping because and Mary Escobar, as you've seen in our other clinics, cystoscopy, continence, all of this is always being done, I think, by the clerk. I think continence, maybe the nurse is doing it, but that's who's going to do this step. So I thought we would be keeping it consistent, but it was clerk.
I think that's what we talked about at the other clinic, so it would have to run, the same process here, but we'll have to, like I said, test it out and see how it goes, but definitely it would be the clerk, because the nurse probably wouldn't go back into that.
Yeah, I mean, it's just an operational decision of who's doing it, but those are the steps are the same regardless of who does it.
Okay, Mary Chen, maybe we can move forward, and just looking at the time, it's 11, we have about an hour left. And I don't know how much more we need to review with the clinic.
Right. I apologize.
Sorry, I have to step out to another meeting, so if there's anything that needs my follow-up, please email it to me. Yeah, thank you.
Thank you, Mary Escobar. Okay. I apologize, but it looks like my second monitor has just died. Okay. I'll share screen, my smaller one. Can people see my screen okay? Sorry, I can't. I'm just working off one screen right now, so I can't see people's faces if you're nodding.
Yes, we can see your screen.
Okay, thank you. Apologize, I'm having some technical difficulty. Just give me one moment. Apologize for that. It looks like the power to the cable got disconnected. I have to just trace it back. Okay, so let me share my screen again. Okay, so going through the colposcopy day of visit. So when the patient arrived, they will go through central registration. It is that where they will print out the armband and the label for the patient and check the patients in. And then the clerk will find the patient, go to the 3D scheduling appointment book, checks the patient in, and once there, the provider can perform the tests, enter any orders in Cerner, any administration work or meds that nurse needs to provide PRN, document interpretations in power charts, and document any finalized BC cancer screening reports, and final copy placed in the share network directory as Jordana was discussing earlier. And then next, the nurse will mark the colposcopy as completed in Cerner, collect any specimen documentations, and document in the minor procedure power form. And after that, the clerk will monitor the share network folder and upload into the report and into the patient's chart. And just need to make sure that the clerk select the right note type. Any questions about the day of visits workflow? We're going to go over the provider workflow here. Talked about the order and how it will have the link for the LEAP treatment and the colposcopy treatment. Now we know for this clinic, you collect non-blood samples. These are the sample that will be collected by the clinic. And there are no point of care testing done in this clinic. And the labs are sent to the internal lab, Dr. Robson?
Yes, to pathology or I guess if it's in, well, some are internal, some are external. So biopsies are all sent to pathology internally. HPV swabs are sent out. They go to BC Cancer, I think, for testing. STI swabs would go to the lab. The only point of care testing that we do pregnancy tests for leaps in the clinic.
I don't see, I didn't put pap tests on here either.
And they're sent out as well.
If you go to the matrix, I think we have the complete.
Yeah, so we have other orders here. I can go through the matrix first. So for their HPV testing, the PAP and the pathology, this is the Cerner order. And this is the matrix regarding the paper requisitions needed or not, and where the sample goes, either BVP lab or the CCS lab. And this is the recommendation for the order entry we're proposing. Okay, let's go take a look at the HPV one. So during a meeting between CST lab team and CCSL, it's mentioned that there will be a change with the HPV order coming through January 2024. And so as such, we have a proposed interim solution for ordering HPV. So the provider will put in the order lab-miscellaneous test for non-blood. And in the specimen type, we'll have the label as HPV testing. Put in clinic contact phone number and the name of the lab test. Rana, are you here? Is there anything else I've missed?
I think Rana just stepped out for a short period. What we're hoping, Dr. Robson, to help with your order entry is we're proposing creating an order set for all of the lab testing. So then this can be pre-populated. So these order sentence with the HPV testing, name of test, the CCSL would all be pre-populated for you. So you don't have to keep entering this manually. So that's what we're hoping to create. And then that VGH and Lionsgate can also use across the enterprise order set that can be used by all providers across, I should say. So this is just like what Mary said, is the interim solution until there is an actual HPV order that the lab will be able to create for you. The timeline is unknown. I think, Mary, you said 2024 sometime?
January, right.
Yeah. Okay.
Yes, because it will probably change for us to some degree once HPV testing becomes the primary screening test as well, because we won't need to do as many HPV swabs, but we're still going to need to do some because we'll need to do follow-up. We have to do follow-up for HPV testing for leaps. And I guess sometimes for people who are HPV positive, although that may happen more in the community, like from then on, when HPV is the way that's being screened, we don't, right now, the only way we can do it is in the colposcopy clinic, whereas in the future, GPs will be able to do it in their office or people can do it at home. So that will be all right. But yeah, whatever way, yes, that we don't have to keep having to enter things. Obviously, ideally, it would be to do it as quickly and efficiently as possible.
And then if it's in the within the order set, however, you would typically 80% of the time, how you would order it, you can save it as a favorite as well. And then so then you can just sign it automatically for each of the patients that that you will see in the clinic. And you can also plan it. So that's what I'm hoping. It would hopefully streamline your order entry for those labs in that matrix that Mary had shown you, because those are your typical orders that you would usually enter for your patients. So it would all bundle it up for you. So that's more to come for that. And we have orders set on board, and hopefully that will pull you into a design session along with the VGH and Lionsgate providers as well.
Okay.
Thank you, Karen. And for ordering the PAP, the order to put in would be pathology, cytology, gynae PAP request. And from there, this is what we call a reference text. There is a link that will show up that will take the provider to the cervical cancer screening lab requisition form. This will be printed out and filled in by the provider and sent with the specimen. Any question with this PAP order?
No, that looks just like what we normally fill out, so that's not a problem.
And in terms of biopsy that's collected, the order that would be placed is pathology surgical request. The nurse can enter ahead of time and then print it out because it is a paper requisition that requires a provider's signature on it. And we know that the clinic is quite busy, so the nurse can pre-order ahead of time, have it print out, or the other way is that the provider can enter this when they have the specimen collected.
So that will be a bit of a change for us, because normally we send the pathologist a copy of the colposcopy requisition. Now, it's not huge, I don't think, to change that. Like with LEAPS, we always send a regular pathology rec, and if we have a vulvar biopsy or something else, an endometrial biopsy usually goes on the usual rec, but normally for colposcopy, they just send a copy of the colposcopy form.
I think it's okay to do that. Like, you don't necessarily have to fill this out. This is actually, the order is to tell lab the specimen is coming, because otherwise the lab isn't prepared for the specimen. So the way Cerner works is you kind of place the order in, it goes to the lab system, and then when they receive their requisition, they can process it quite quickly. If they don't have to have an order, there's a delay, because then they have to create the order in Cerner, well, or Lab SoundQuest, and sort of do their steps. So this is kind of the happy medium. It's not ideal, but I think you have to fill out this in order for the lab to know.
I think it's more like a receipt, Dr. Robson, that they've confirmed that they received the sample. So if things get lost along the way, because they receive all of your samples at the Richmond lab and then they send it to VGH. So at some point, it's sort of like a tracking thing that they received the sample and then sent to VGH as well, just like what Jordan was saying. It just helps.
The pathology doesn't get sent to VGH. That's done at Richmond lab. It would just be the HPV and the PAPs that would be sent.
Yeah, so this order is a workflow thing. I've seen it done in different ways. You could have it placed like ahead of time, or the nurse could place it immediately at the beginning of the procedure, or you can wait during the procedure and the nurse can place the order. It's just really an order. Like I said, it creates that tracking number, because your specimens are not going to be labeled with like they're just labels that someone has to handwrite the details on it. So this says this is the order for these specimens, and it's sort of just, like I said, it's really for tracking. So your specimen, if it gets lost, then they use this number to track the specimen. But like I said, anyone can place this order at any point. So if you find that, every patient has a pathology surgical request, you could have it like sort of placed for every patient, and then the paper spits out. You just have to send the paper with whatever other document you normally send, you could send as well, and send that to lab. It's your choice when you want to place it, or sometimes you don't do pathology.
We almost always have pathology. The only time we don't is if the patient's pregnant. So so it's rare to not have pathology. Almost everybody has it.
Yeah, so it might be just something that then the nurse can place the order right at, like, you know, when they check the patients for the day, place the orders, the requisitions print, and you don't need to worry anymore about it. It just might be the way you have to set it up.
So during the colposcopy enterprise overview session, there's been requests to add the most frequent orders available into the end page, specifically in the quick orders. So the two new specialty diagnostic order, which includes the gynae colposcopy and the gynae leap, will be added to the gynae outpatients tab here. So it's not built at the moment just because right now this is blocked by the clinical indicators that we need to update for those orders. So once we get that up and going, we can also include that in the video.
I'm sorry, will that include the vulvar form as well then? In that?
Right, so this is the one that we received recently. So with this here, just want to ask you a couple of questions, or a few questions. So with the vulva form, who is this filled out and when is it filled out during the workflow?
Well, I guess it would be filled out. So basically it's a very similar form in terms of what's filled out. It just wouldn't go to the cancer agency. The colposcopy screening program doesn't want copies of this. So I guess it would still, normally what would happen is the upper part of it would be filled out again, usually by the nurse in the clinic when they interview the patient. Now, sometimes they don't know that. I mean, I guess it's determining in advance if somebody needs this. And as I say, it's not going to be very often. But then, and then the middle portion would be filled out by ourselves, and there may or may not be a biopsy in this. So if there's a biopsy, then we would have to wait for the biopsy to come back to finish it. If there was no biopsy, it could be just filled out and sent directly.
So sent to where directly?
To the referring care provider.
Okay. And so this form is filled out when the patient is here, the nurse fills it out first, and then when you do the procedure, that's when you fill out the middle part?
Correct.
Okay, and depending if there is a biopsy, then
it would go, it would have to wait for the biopsy to return, just like the colposcopies do. If there wasn't a biopsy, it could just be kind of filed immediately and sent immediately.
Dr. Robson, for your provider notes after the procedure, does this not cover a lot of what's in this form already?
You mean in a colposcopy form?
Yeah, so post-procedure, when you write the colposcopy procedure, post-procedure documentation, are a lot of this covered within your provider documentation already?
Well, yes, it would. The only thing that is post-procedural is results of any biopsy that would have been done. Right, so that just it's basically just a colposcopy form for the vulva, and the colposcopy screening program doesn't follow up vulvar colposcopy. So, as I say, it's not a huge part of our clinic. Quite a few of the people that are getting vulvar colposcopy need cervical colposcopy as well, but there are some that are being followed just for pre-cancer changes of the vulva, and they have to come kind of every 6 months for 3 to 5 years, depending on what they've had. And this just allows us a form that is separate from the regular colposcopy form in order to document those findings, but without sending the form back to the colposcopy screening program.
Needs to go back to the referring once the biopsy has been received.
Correct.
Okay.
So it could be stored just like the regular colposcopy form, and then once the biopsy is back, when it's filled in, it could be just pushed again to that same file where it gets sent. And I guess we could just write on it, if there was a space, to write "do not send to BC Cancer" or "do not send to colposcopy screening," which is what I generally do now.
Is there a fillable PDF form version of this form? That you know of, Dr. Robson?
No, I do not. The only copy I have is that one. And as I say, we had not been using that at the colposcopy clinic. Usually I'll just write on the form, like, "this is vulvar, do not send," and use the regular colposcopy form. But technically it would be better to have this form, I suppose. So if it can be used, then I suppose it would be a good thing to have, and the other sites might want to use it as well. I guess that's, but yes, I don't have any other formatting of this than that. And maybe it needs to be modified to make it a little bit more simplified, which I can look at it and see if we could just simplify it a bit.
What we can do in the meantime is we can load it into what we call Forms Fast, which if that is the case, it would have to be a manual paper that you fill in, as well as the nurse fills in partial of it. It may take a different workflow than the colposcopy form, because the colposcopy form is more of the electronic fillable PDF. So this one, if it's more paper, that needs to be printed out and manually filled in, it can be scanned into the work queue monitor instead of saving it into the shareable file way that the colposcopy will take. So
yeah, just as long as it's easy to access, I think that would be, whichever would be fine.
Okay. So we can propose to put this into the Forms Fast. That can be printed and start filling in by the nurse, and then keep in the chartlet until the results come back, and then it can be scanned into the work queue monitor, and then index into the patient's chart, and then that will automatically distribute out to the referring physician, the same way that the colposcopy, once it's indexed into the patient's chart. So we can walk that through as well. So very similar, how you would index into the patient's chart. Okay. If that's okay, then that's what we can do. So Mary, we can note that.
Okay. Thank you, Dr. Robson. Thank you. Okay, so moving on forward, just checking on the time here. There was nursing workflow demo slotted for this presentation, but just for the interest of time, I'm just gonna skip forward to tasking and documentation, and then I will include the nursing workflow in the video that we will be sending. Okay. Want to highlight when this is a part of the nursing documentations, when the colposcopy procedure is done, this is where the nurse will go into to indicate that the procedure is completed. So the nurse will go under the menu bar, under the single patient task list, where you see there is a gynae colposcopy in clinic or the leap. You right click and you click chart done. And this is a copy of the new requisition for the gynae future order. And this is a screenshot of the nursing documentation that will be used for the procedure. It's under Power Form, and the Power Form is called Minor Procedure Power Form. And here you see that there's all the tabs on the left. You can go into, and so you can fill out any allergies that the patient has, any medication histories, any procedure history you can also view or add. And then there is the minor pre-procedure checklist. And a nurse can document the vital signs and measurements and update any progress notes as needed. So this will be the main form, electronic form that the nurse will fill out during the procedure or for the procedure. Sandy, do you have any questions about this power form?
No, not at this time. I know we don't do vital signs on our patients, though. We just hook them up to the monitor to see the efficacy of the lidocaine with epi. So,
Okay. So these fields are not mandatory fields, so it is entered as per clinic's discretion.
perfect.
Okay. Next, we'll go to document routing.
Oh,
Okay.
sorry, I do have one question. Is there
Mhm.
anywhere we document a patient is pregnant or not?
Karen, I think that was identified as missing on the minor procedure power form. I don't know if that's something that we could ask.
I can take that back.
Yeah, I
And
think it
so-
actually came up at the VGH session too, so yeah, Mary, maybe we can connect with the VGH group that's doing gynae.
Okay, thank you. So going back to the patient's journey, when the patient arrives at central registration, they will get a face sheet printed as well as an armband label. And along with that, they'll get 4 patient labels and 4 specimens label, and that is all set to default. And that can change if the clinic finds that it is not sufficient as you start using Cerner. But you can also print them ad hoc. So just want to validate with the clinic here. Can we start with this number of labels, or does the clinic feel like they need more? Sorry, I don't hear anything. Sandy or Milena?
Sorry, Milena just knocked on my door. So
Oh, okay.
can you repeat the question?
Okay. So when the patient arrives, they'll go to central registration, and from there they will get a face sheet printed as well as an armband. And as default, it will be 4 patient labels printed and 4 specimen label printed. Would that be sufficient as a default setting for the clinic?
I think so. I don't think we take more than that for specimens, that's for sure. But if we need more, we can print more off at that time.
That's right. You can print out ad hoc. And we'll show you in the training on how that can be done as needed. Okay. Going over to the printing rules. Robin, are you available to speak to this?
I can do it. It's Jordana.
Sorry, Jordana.
So this is when requisition is ordered internally, it will not print out on the unit if it's for a schedule as outpatient. If I know this doesn't happen in your clinic, if by chance a patient was an inpatient and you wanted or they wanted to do a colposcopy on the patient, the requisition would print automatically just to flag the clerk that's important. It's an inpatient. I know this is maybe rare at your site, so that might not happen. But it would just print out. If they received externally via the fax, we already talked about this, they just come in via fax. There'll be no paper when something's sent by fax. And then when the patient checks in, the requisition will print out. So just if you remember, there's no face sheet anymore coming in with the patient. So what'll happen is the patient will check in at the main check-in in your ambulatory space, and then that requisition will print out. It says the colposcopy, it'll have those clinical indications. The only caveat is if we don't end up filling that information, it will say see the other requisition. So this may become less important to you, but that is the requisition that will print. And if you want it turned off printing, we can also turn it off, but that's what we'll start with. Any questions?
I'm good.
Next slide, Mary. So the in this clinic, it sounds like most of the time the documentation is going to be done on that, like the screening for that BC cancer screening form but if there is a documentation, I guess that's not true. After your visit, when you do, the physician can do an interpretation note, and they'll do that in the system. And so that's just a regular note, and that goes to the PCP, the referring, and the author. You can also add CCs. If we scan the result, or what we're calling indexing, so if, when you save that file to that WorkUM folder, or, anything else that you scan in, you can have it distributed, but our general rule of thumb is if the document is over 8 pages, what happens is the EMRs and the community don't like it, so they reject it. So we generally say that, if you're scanning anything, that it should be 8 pages or less. I don't think you have an issue with this clinic, the results. You can go to the next slide. As we showed you before, when you index, the note types that we have for this clinic are the colposcopy diagnostic study. When you use that one, it automatically goes to Cerner, to Care Connect, Accelerus. So when you add a physician, or when we added the BC Cancer cervical screening, it uses the Accelerus distribution method. So nothing for you really to worry about, but it's kind of an electronic fax, if you will, to those EMRs and other systems, or whatever they use to receive the results. If you use the one that's called data on the end, then second note type there, it doesn't automatically send to Accelerus, so it just sits in Cerner and Care Connect. So I think the one you said, the vulvar form, if you end up using that, you don't want it to be sent out to anyone, then that would be the note type you use. The external one is just refers to if a patient came from Prince George and they came with their colposcopy interpretation from up there, then you could scan it into the chart. It's just a way to get those results into the chart that a patient gives to you, or you've received from someone else. So if you get miscellaneous results that are done somewhere else, or someone came from Alberta, they brought you their report, and because you normally file in the chart, we use the external note type. But again, those will all be going over when we do the show you in training. Yeah, sorry, go ahead. Next slide. Mary, do you want me to go over this workflow?
Oh, sorry, I was just talking on mute.
Oh, okay.
Sorry about that.
Go ahead.
So we heard from this clinic on a rare occasion that the patient may need to have more time to recover after their procedure. And as such, the current workflow is that the nurse will call over to the endo recovery bay to see if they can have space for the patients to recover, so free up the procedure room. And so currently we have a proposed solution for patient transfer. So in the ambulatory organizer, which is like the agenda for the clinic, we're proposing that the location we add an extra location that would say endo WR waiting room. And so with that, once the patient is there, it indicates the patient is recovering in that section of the unit. So the high level workflow for this would be the colposcopy nurse calls over to endoscopy of patient transfer for further monitoring. Then patient gets transferred to endoscopy as per option outlined it. The endoscopy nurse will continue to monitor the patient and document on iView or in the minor procedure powered form as needed. And with this here, Dr. Robson, once the patient is deemed ready for discharge, we're proposing that the colposcopist will need to enter a discharge order for this patient.
I think that's more of a question to Dr. Robson, Mary.
Okay.
Currently, so from my understanding from your current state right now is the patient is transferred to the endoscopy recovery area. And then the patient gets discharged from there. How do the endoscopy nurses know that the patient is okay to be discharged? Our understanding is that you don't enter an order right now for discharging the patient from there. Or do they call you to check in and say the patient's last blood pressure, or this is how the patient is now? Is it okay for the patient to be discharged? Is that how it is, or do they have a criteria that they go by in order to discharge the patient without an order?
I think it's so long since we've needed to do that I can't even really remember. It's a pretty rare event. Usually it would be probably just a verbal thing where they say either the patient's feeling fine now, they seem okay to go. And if we're kind of right in the middle of the clinic, we might say, okay, that's fine, they can go. If we were concerned about them, we might go and check that, their bleeding isn't ongoing or that something else isn't going on. But yeah, it would be generally, if they're going to be monitored for a little while, it would be given probably verbally. But an order of some kind would generally be given. I guess that could be, entered somewhere too, if there was some place for it, which would be a good thing to, there should be some way of documenting that, and then allowing that, maybe I don't know whether that's having criteria for them to be discharged that are in the system, or whether it's just entering either a verbal or a otherwise order that they can go.
Quickly, that the nurses in the endoscopy space would give you a call to say that this patient is either ready or continue to deteriorate.
Yes, you would hope they would. They're right there, so it's usually they would just walk over and tell you things. So,
and depending on the situation, if you're in the middle of the clinic, you can either just give a verbal order, or if you have the ability to enter an order, that would be ideal for them as well. So
either way would be fine.
Okay, sounds good. And we can highlight that for the endoscopy nurses as well, that would and review that with them as well, that they can give you a call for any type of the situation that we just outlined. Okay. And also, so this workflow we're hoping to review with Mary Escobar as well and Val. So Jonathan, I know that the readiness meeting has been canceled until the New Year's, I believe. So it's a possibility that we can have a short ad hoc meeting to review this with the both of them. That would be great. It would just be a short meeting with them.
For sure. If you can send me over the parties from your end, I can find a time between the calendars just for a short 15 or 30 minutes so we can get all of that crossed out.
Sounds good.
Yeah.
Thank you.
Thank you. Okay, so that concludes the presentation for today for the validation session. Does the clinic have any questions regarding what was demonstrated today or what was shown to the clinic?
I guess we forgot to ask Sandy if she has any question regarding that proposed solution or any concerns on your end, because I'm sure Mary Escobar would probably ask us if there's any concerns on your end.
No, you mean with that last part with the discharge? Or just in general?
General, I think it really is a very similar workflow that you currently do now. You would call endoscopy to see, just before you transfer the patient, and then communicate to the clerk to transfer or change the location status to the endo waiting room that's there on the ambulatory organizer. And that's basically it on the colposcopy clinic end, and then endoscopy will take that over from there.
I think, Karen, just to clarify, so we were expecting this view is the view that your clinic has. So we would expect that probably, I think it would be nursing, you just quickly change the location. It'll take 2 seconds. You just change it to the endo wait room. On the endoscopy side, they will also have to put the patient into the wait room as well. So and discussing with them, their nurses will do that on their side because they'll be receiving the patient. So yours is just so that the patient really hasn't left yet. And that potentially Dr. Robson might get a call or something. That's why you do it. They're going to do it as well because they have to see the patient. Yes, go ahead.
My question is, designating it as a wait room can be kind of confusing because we do have 2 waiting rooms here. One where patients are waiting to go home who have been sedated, and then we have another area of patients waiting to come in. So I would rather it be designated as a recovery bay. Does that make sense?
Yeah, what is they usually use those little acronyms. You want it like RB or something? Does that make sense?
Yeah.
We haven't submitted the change for the actual, like the location. So I
Okay.
think we could do that, Karen. We could ask if it could be RB.
So Sandy, is that okay? So it would just be RB instead of WR.
Yeah, I think that, yeah, we have enough WRs.
Yeah, no, it makes sense. I think we originally were told lounge bed, but I don't know. That was the one that Core gave us, WR. But if RB makes sense to you, then we'll request that.
And this is different, right? Then because so we have a room beside the colposcopy room where sometimes if patients feel a little bit faint, or either tachycardia doesn't resolve really quickly, or where they have a little bit more bleeding perhaps than the norm, they go there and usually just lie down for 10 minutes and then they go on their way usually after that. That's different. You're talking about somebody who needs to be monitored and needs more attention, right? Which, like, I don't even remember when the last time that would have happened. Years ago, I suspect. But so that's pretty just so there's obviously you want to have all contingencies built in, but that's different, right? Assume if they're in just lying down for 10 minutes after the colposcopy in the colposcopy rooms, that isn't the same, and they don't.
Is it a different room than we have built? So sorry, now that you're saying that, I didn't hear that you sort of lay them down.
They just have that option if they wish to. That's where they change. Often where they change after the procedure, there is a bed in there that they can lay down in if they feel faint.
What do you call that room though? Do you have a name? Sorry, I'm just looking for the names of our rooms here. Hold on.
It's kind of our post-op change or post-procedure changing room, because we have the bathroom as the pre, and then it's just for the flow of the clinic, right? Because you can't have everybody using the one raw washroom to start and finish. Otherwise, you just get a backlog. So it's usually bathroom as a pre-preparation into the room, And then after the procedure, they go into kind of like a post-procedure changing room, but there is a bed there if they need to lie down for a few minutes. They would still be in part of the colposcopy clinic, and the admitting nurse would still be keeping an eye on them.
So I guess the question is, do you want to have, like, the rooms we have right now is colposcopy 01 and colposcopy weight room. If that patient, you're still keeping an eye on them, do you want to, like, normally it would just be 01, right? And then you're sort of finished with them. But if you're kind of keeping an eye on them and a new patient's in the room 01, do you want us to add an additional room that you could sort of put them in on the, like, on this ambulatory organizer? Would you like another room? Or do you think it's 10 minutes and by the time you change it, they'll have gone?
I think just having the one room, because I think if you add one more room, it gets a little more confusing, because really it is just a changing area.
Yeah.
But it is the opportunity. Some people get cramping or whatever and just need a little moment to just gather themselves. And so we just have a lying, you know, we'd lie down, but it doesn't interfere with the other the next person or anything. So yeah, does that make sense?
Oh, it makes sense. It's just like I said, right now we only have the two. So if you wanted us to add in another one, like Copo RB, like recovery bay, we could add that if you felt that it was necessary, like that you wanted to track that they're, you know, sitting in that room.
I think it probably doesn't matter, because obviously if they had a significant problem, they would go into the endoscopy area where they could be monitored. These are people, this is the more common scenario where they just need a few minutes
Okay.
rather than needing, you know, an hour or whatever of monitoring.
Yeah, like, cause you're saying if they need an hour, you're putting them in endo. Is this kind of what you're saying?
Exactly.
Okay, so yeah, maybe we just leave it, and after we go live, if you decide that you do want to track them, we can add another room at that point. Takes a little bit longer, but we can obviously do it.
Thank you. All right, so I will just update the document that we're changing the endo WR to endo RB. And for now, we're okay to leave the post-procedure changing room outside of the build. Okay. All right, so this concludes the presentation for the validation session. Does the clinic have any questions regarding the workflow that's been demonstrated today?
Not at this time. I'm sure on the day we start, I'll have lots.
Rana?
Hi, this is Rana. I'm the clinical informatics specialist with the lab. My apologies, I had to step out when the lab section was covered. So I just wanted to ask if anyone has any lab related questions that I might be able to address. Okay, all good, thank you.
Thank you, Rana. So we'll talk about next step here. So one more scheduling validation session coming up on October 17th. Also, we'll be doing cutover planning as part of the next step, and also the self-directed online learning. This is the portion where the clinicians and providers, as clinicians, will review the learning material. And also added from this session will also be a video recording a more seamless workflow without the glitches, and then send it to the clinic.
In addition to that, Mary, I believe there's also a workshop that will be provided for the clinicians as part of their training.
And sorry, the 17th, I don't think I was aware that's not a meeting that includes me. I'm assuming. I don't think I was made aware of that, and I'm away on that day, so I won't be there.
That's correct, Dr. Robson. I believe Mary Escobar, Jonathan, and Melina will be in attendance for the scheduling validation session.
Okay, sounds good, because yeah, scheduling hopefully doesn't have to involve me.
Great. Well, thank you for everyone's time. We'll take your feedback back and update you as soon as we have the documentations approved. Thank you.
Thanks, everyone. And Karen, please feel free to reach out to me once you've have a time in mind and the group in mind for the Val and Mary meeting.
Sounds good.
Okay.
Thank you.
Thank you.
Thank
Bye.
you.
Thank
Bye.
you. Bye.